Welcome. In this video, we'll explore Pedicle autografts, a set of periodontal surgical techniques designed to cover exposed tooth roots and restore gum health. These procedures are especially valuable for treating gingival recession, improving both function and aesthetics. We'll break down the main types, their indications, advantages, and step-by-step methods. Whether you're a dental professional or just curious about advanced gum treatments, this guide will walk you through the essentials, starting with the classic laterally displaced flap and moving through modern modifications and alternatives. Let's begin by understanding the foundation of these grafting techniques. The laterally displaced flap, also known as the sliding flap operation, was first introduced by Grupe and Warren in 1956. This innovative procedure involves moving a section of gum tissue from an adjacent area to cover an exposed root. It's particularly useful when there's enough healthy gum tissue next to the recession site. The main advantage is that it requires only one surgical site, which means less trauma for the patient. The flap maintains good blood supply, promoting healing and increasing the chances of success. However, it's important to understand both the benefits and the limitations before considering this technique. Why choose the laterally displaced flap? There are several key advantages. First, the procedure involves only one surgical site, minimizing patient discomfort and recovery time. The pedicle flap retains its original blood supply, which is crucial for healing and graft survival. This technique is especially effective for covering isolated, denuded roots, provided there is sufficient donor tissue laterally. These benefits make the sliding flap a preferred choice in suitable cases, offering predictable results and improved aesthetics for patients with localized gum recession. Despite its benefits, the laterally displaced flap has some limitations. The amount of adjacent keratinized attached gingiva restricts its use, meaning it's not suitable for every patient. There's also a risk of recession or even dehiscence at the donor site, which can compromise the outcome. This technique is generally limited to one or two teeth with gingival recession. Understanding these drawbacks is essential for proper case selection and for discussing realistic expectations with patients. The laterally displaced flap is indicated for covering isolated denuded roots, especially when there's sufficient width of interdental papilla and adequate vestibular depth. However, it's contraindicated in cases with deep interproximal pockets, excessive root prominence, or significant loss of interproximal bone height. Deep or extensive root abrasion also rules out this technique. Proper patient selection is critical to ensure optimal outcomes and minimize complications. The procedure begins with an incision around the exposed root, removing a band of marginal gingiva. This tissue is carefully resected using a scaler or curette. The exposed root surface is then planed to ensure it's clean and smooth. If any granulation tissue is present along the incision edge, it should be meticulously removed with curettes. This preparation is crucial for creating a healthy environment for the graft and promoting successful healing. Next, a vertical incision is made from the marginal gingiva into the mucogingival junction using a No-15 blade. A crevicular incision connects this vertical cut to the defect. The flap is then raised, either as a partial or full thickness depending on tissue characteristics. Partial thickness flaps heal quickly and reduce bone loss risk, but may not survive if the gingiva is thin. Sometimes, a short oblique incision is added at the distal corner to help slide the flap without tension. This step sets the stage for successful lateral movement of the tissue. Once the flap is mobilized, it's carefully slid laterally to cover the exposed root. The flap is then sutured to the adjacent gingiva and alveolar mucosa using interrupted sutures. Proper positioning and tension-free adaptation are essential for optimal healing. This step ensures the graft remains stable during the initial healing phase, promoting integration and coverage of the recession defect. After suturing, The surgical site is covered with a periodontal pack to protect the area during initial healing. The pack and sutures are typically removed after 1 week. Antibiotics are not always necessary, but analgesics are prescribed to manage pain. Healing may occur via connective tissue adhesion, attachment, or long junctional epithelium. Some studies suggest that citric acid root conditioning can improve outcomes. Proper postoperative care is essential for a successful result. To address the limitations of the original technique, several modifications have been developed. One approach uses converging oblique incisions over the recipient site and a vertical or oblique incision at the donor site's distal end, making the flap wider at its base. Another modification leaves the marginal periodontium at the donor site undisturbed, reducing the risk of recession and bone resorption. These adjustments help expand the indications and improve the predictability of the procedure. The double papilla flap, first described by Weinberg and later refined by Cohen and Ross, is another technique for root coverage. It's indicated when the interproximal papillae are wide enough, and when attached gingiva on adjacent teeth is insufficient for a lateral pedicle flap. This method is also suitable when periodontal pockets are absent. The double papilla flap offers a predictable solution for specific clinical scenarios. The double papilla flap minimizes the risk of alveolar bone loss, as interdental bone is more resistant than radicular bone. The papillae provide a greater width of attached gingiva, enhancing the stability of the graft. Clinical predictability is generally good. However, the technique is sensitive and requires precise joining of the small flaps to function as a single unit. Mastery of this method is essential for consistent results. The coronally repositioned flap, or coronally positioned flap, is ideal for aesthetic coverage of exposed roots and for reducing tooth sensitivity caused by gingival recession. It's especially useful for treating multiple areas of root exposure without involving adjacent teeth. This technique boasts a high degree of success and, even if unsuccessful, does not worsen the existing condition. However, if the keratinized gingiva is inadequate, 2 surgical procedures may be required. This procedure can be performed using 2 main techniques. The first involves making 2 apically divergent vertical releasing incisions from above the cemento-enamel junction, preparing a split thickness flap at the ends, and connecting with an intraclavicular incision. A full thickness flap is raised facially, and the root surfaces are thoroughly debrided. Citric acid may be used for root conditioning. A horizontal incision through the periosteum releases muscle tension, allowing the flap to be positioned coronally and secured with interrupted and sling sutures. Periodontal dressing protects the site during healing. If there's insufficient attached gingiva, a 2-stage approach is used. First, a free gingival graft is placed, followed by coronally repositioning the flap after 2 months. The semi-lunar flap is another option for minor recession, 2 to 3 millimeters. It involves a semilunar incision following the curvature of the recession, with split thickness dissection and no need for sutures. This method avoids vestibular shortening and preserves papillae aesthetics, but is limited to small defects and may require a free graft if there's underlying bone loss.